which is key, obviously. You can do multiple treatments with one device. It's 5 to 10 minutes of clinician time total. We would expect that you would have ROI in 20 to 30 patients. 4-year warranty, pretty simple, pretty straightforward, not a lot to go wrong on this device. So just to get familiar with what the parts of the device are, this you'll see in this next video I'm going to show you. This is a preheater. And the only purpose of that is to preheat these 3 different instruments that we're going to use. The handheld device, of course, is lithium-ion powered, has a heater in it. And all we're doing with the preheater is saving battery and saving your time. Because if we didn't have the preheater, you could use the device by itself, but it's going to take you 3-4 minutes to heat up these instruments to 110 to 113 as the treatment temperatures, and there's just really no reason to do it. So we created this preheater such that now switching times are more like 45 seconds to switch instruments and get it up to speed, up to temperature, I should say. And each of these instruments are autoclavable. You can sterilize them using alcohol, whatever your current method is that you would treat any surgical or stainless steel instrument, you can do with these instruments as well. And the 3 steps I'm going to take you through here in this video, thermal debridement. So you're all familiar with debridement. We've added heat to debridement. So what does that do? So, what the feedback I get from clinicians, I can use less pressure. I'm melting, the caps off the glands. That's the feedback that we're getting. So pretty easy, pretty quick, less than 2 minutes. Up to you. Maybe you'd have your tech do this, maybe you wouldn't. It's really kind of up to you and maybe the laws of your state. I'm not sure how each state would handle that. The thermal lid massage, definitely have your tech do this. It's 2 minutes per eye, using ultrasound gel, applying heat, light pressure. You're all familiar with that idea. And this is, all using heat and light pressure to get ready for thermal expression. So now we go in with an expressor that is heated, external paddle only, external to the eyelid, and you are going to use controlled pressure, so it's not excessive pressure, doesn't hurt, and you're going to be able to express those glands very easily. So the treatment itself, the whole protocol is very comfortable. I've had it done twice. I'm ready for a 3rd one. So whoever wants to give me that one out there in the audience, I'm happy to come by. So let's go ahead and look at each step. We're just going to kind of hit the highlights here. This is our in-service video, so it's about 7 minutes long. We're not going to watch the whole thing. Don't worry. So I'll turn down the music here. So you've kind of heard me talk about this already, so I'm going to go ahead and skip forward here. I didn't want to skip that far. So here we are loading the first instrument. That's the debridement instrument, and it's just a double click of the control button that says, yep, I've loaded the instrument. And then it's going to take about 45 seconds for the device to check temperature, assuming you're using the preheater and it's heated for 5 minutes or so, it's going to be ready to go. What you just saw there were some anesthetic drops, for this treatment. And you can see he's just using light pressure and just scraping off the biofilm and kind of decapping those glands. Just pulling down the lower lid now, pretty easy access there. And the temperature of that instrument is 42 C. Okay, so now we're going to the second step, which is thermal massage. Again, loading the instrument, just double clicking it, saying we're ready to go. Now this one, we are going to put some ultrasound gel on the tip just to help with heat transfer and decrease friction. It does have a 2-minute timer built in, so you just press and hold the mode button, you're going to get a 2-minute timer. Again, this is very comfortable. Patients typically love this step, and I have to say, I actually love debridement. I didn't think I would, but I really did. It felt really good. Just a tip came up there in terms of battery life. You should be able to get two treatments, so 2 patients on 1 charge. If you're planning to do a whole bunch in a row, you can plug in the instrument while you're doing massage. As you can see, it's not fine motor control. The lid is closed. So you could have that plugged in, and that way you're saving battery, and you'd probably get another patient out of it. So we'll go ahead and move on here to expression. So we're just he's gonna go ahead and load that instrument as well. And we're gonna apply the anesthetic drops again. You know, it's been 6 or 7 minutes maybe since the first drops went in. So you can access both the upper lid. So he's just kind of pulling up the lid there. And depress and hold. The pressure is controlled, so you can't put more than about 10 psi on that eyelid. It locks out such that you can't exceed that. And you can see the angle of those paddles. So he just switched it now. So he's doing the lower lid. He's got easy access to the lower lid. And for the upper lid, you would just flip the device around, and the angle would be correct for that as well. And here you're going to see some pretty good expression, because we've debrided, we've massaged, and again, we're keeping heat on that right there. So that is pretty much it in terms of the 3 steps. As you can see, whoops, that is not a whole lot of in-servicing, new learning required to use the MGrx.
Thank you, David, for this opportunity. It's a pleasure to be here. And if any of the viewers watching this attempted to the other day when we had a little bit of a Zoom misadventure, I do apologize for that, but it's a pleasure to be here and record this and have a second at bat, if you will. But asked by David to present my experience with MGrx treatment along with IPL treatment for dry eye secondary to MGD. And my name is Lee Newton. I'm an optometrist, private practice in Bay City, Michigan. You advance the slide here. So Michigan College of Optometry 2000, so about 22 and a half years in practice. Rigorously independent. And what I mean by that is I don't have to answer to anyone to provide the kind of patient care that I want to provide. If I want to offer a service, offer a treatment, buy a piece of equipment, that's on me, and that's it begins and ends with me in private practice. That's how I've always had it. I've had that luxury, and I wouldn't change it for the world. Probably like a lot of you who are watching this, probably optometry, maybe some ophthalmology. So far in practice, I haven't found anyone who's willing to pay me to speak on their products or their company on behalf. So I'm not a paid speaker, so I really have no relevant or pertinent disclosures. And my websites, my practice website, newtoneyecarecenter.com, my personal website, drleenewton.com. So I found myself about a year ago just so burnt with not being able to help my dry eye patients to the level that I wanted to, and got burnt with I say the big pharma mess. And probably what I should have added is the insurance mess. Well, we'll pay for your prescription dry eye medication this year, and we know it helps you, but next year we're going to change our mind, and your copay is going to go up to a car payment a month, and it may or may not work for you, and it may not continue to ameliorate your symptoms. So just got so burnt with that, the whole, as I say, the drops, the plugs, and the drugs. And I just didn't feel like I was doing the best job that I could do for my dry eye patients. And as technology continued to progress, I realized that I needed to add the capability of my biography to my practice. And that's kind of morphed into the IPL and MGrx all within roughly a 90-day period in 2022. And so I did some research. I checked in with our social media discussion groups and clinical evidence and white papers. What were people doing with meibomian gland expression and thermal expression and IPL? And it seemed like the common thread was IPL seemed to add heightened the expressibility of the meibomian glands. And so the two treatments seem to work synergistically together. And so from that point, right from the beginning, actually, I incorporated the MGrx into my IPL protocol. And what I typically do, unless there are other extenuating diagnoses or circumstances, is we typically do 5 IPL sessions. The first 4 would be 2 weeks apart typically, and the 5th one would be about a month after the 4th. And immediately after the 2nd and the 4th IPL sessions, I do MGrx. And when I say immediately, I mean the same day from one room to the next. And I also say treatment may vary, obviously, based on patients' needs and symptoms. Everybody's a little bit different. I do have a gentleman that's, I felt like we're going to start with MGrx. We're going to wait a couple of weeks and then start the IPL sequence. So everybody's needs may vary slightly. There's no cookie cutter approach. So I had this patient that I selected for the case study that was, her initials were TLC, and that's also what she needed because nothing that I had provided for her to date had really ameliorated her symptoms. So what I felt was the classic MGD based dry eye patient, dryness, burning, sandy, gritty, fluctuating vision, foreign body sensation, couple hordeola per year. Okay. Her systemic health was relatively non-contributory. She didn't have a lot of staining. I didn't really feel she had aqueous deficient dry eye, but she did have the classic signs of MGD with the inspissated glands with caps. And she also had moderate anterior blepharitis, which was, I guess, a comorbid. It didn't really help matters. So things that we had failed with were artificial tears, temporary plugs, a home compress, and steroids maybe got us out of trouble once or twice a year. So consider her my biography. I apologize. I guess these are okay images. The viewing software didn't let me download only view, so I had to take a screenshot with my phone and then kind of crop it. But if you look at the upper and lower eyelid meibography, you're getting moderate dropout and moderate hypertrophy. So just classic signs of, this patient's meibomian glands need TLC. And so that made me think that she was, of course, just an awesome and a slam dunk candidate for both the IPL and MGrx, right? When I say wrong, actually, I mean, any prudent eye care professional would agree that, yeah, she was a slam dunk candidate, but it didn't go that way for her. And honestly, I don't know why. I mean, we treated the anterior bleph with, separately, but the IPL, the photosanitizing effect from the IPL ought to have taken care of that. It ought to have done something for her. After 4 IPL sessions, she really didn't have any affinity for continuing with the 5th or feel that it was doing anything for her in any way. And so we kind of went back to ground zero, back to the drawing board, and said, what if anything that you've experienced over the last several weeks had helped you? And she had said that, a couple days after you did that thermal treatment, that actually my eyes and my lids felt pretty good after that. So we shifted gears, and our current plan is maybe to look at the MGrx when her if I can talk now, edit that out, David. Symptoms flare up again, but maybe every 3 to 4 months. In retrospect, I think that, and it's hard to explain to the patient because they don't understand it to the level that we do, but IPL had to make her meibomian glands more expressible. So I do think it helped. She just didn't feel any symptomatic relief from the IPL itself, just the MGrx. When we went back to the drawing board, I was a little bit more aggressive, or I went back and I recommended that she actually take a fish oil supplement. That we didn't skip over it before. It just wasn't something that she was interested in. So I left it at that. So I got her on a good fish oil supplement, and she's due for a follow-up pretty soon, which is a few months after the second MGrx treatment that we did. So there's a little typo on this slide. The second MGrx was in that IPL sequence, and we didn't wait a few months to follow up. We actually reached out to her about a week after, and she felt that her symptoms were getting quite a bit better at that point in time. So what I learned from that is, as with any patient, needs vary. Don't employ a cookie cutter approach. Don't be afraid to shift gears and to customize treatment based on their needs, their clinical appearance and the clinical picture, and their feedback from treatment that you've already provided. Another point would be, if the patient has MGD to the point where you really don't need the meibography to diagnose it, consider MGrx first, because that might get things flowing just a little bit better, and then help the whole sequence work more efficiently with the IPL and the thermal expression. So those are the pearls that I learned from that case. I have a few other highlights. When I talk about MGD care to patients and the different treatment options, I disclose that every patient that I've treated with IPL and MGrx, okay, I don't know what my N number is now, but it's between, I would say, 15 and 20. We're about 6 months in. Every single patient, I tell prospective patient, has gotten better except one. And I tell them the story of patient TLC. But what I noticed is that when patients start the IPL treatment, they're all excited about the visit that includes the thermal expression with the MGrx. They'll say things like, "Is this the visit that includes the eyelid massage?" So I kind of get a charge out of that. IPL and MGrx are both premium treatments. The IPL, they're willing to endure the ultrasound gel all over their face, the rubber band snaps, the spicier treatment that it is, to endure that for the benefits of it. But the MGrx is more of a spa, kind of a feel-good treatment, more relaxed. Other things I've noticed, I had a gentleman, 75-year-old with moderate MGD, and he wasn't interested in IPL, and everything else failed. Compresses, he didn't really feel like fish oil was doing much for him. Emollient artificial tears, I don't think we did any plugs with him, but I said, and he had one eye that was worse than the other. I think it was his right eye was just bugging the heck out of him. So I'm like, let's just do the MGrx. Don't even worry about the cost. And that's one of the things I love about it, is that there's no per click fee. So I have the latitude to do that. Like, let's just do this. Let's try this. Let's give it a week. See how you feel about that. And I had my staff call him the next week, and he did say, "This is the best we only treated one eye, but he did say, my eyes have never felt better." So sigh of relief. I can help this guy. When I'm talking to a patient about treatment options, I just try to keep it simple and not overwhelm them with information. I present 3 different general levels of care. I call them levels 0, 1, and 2, because why would I make it as simple as 1, 2, 3? The reason I designated level 0, because I told patients level 0 stuff, you don't need me for that. I mean, you and I talk about, hey, let's go this route, but you don't need me to administer the care. And so that's drops, that's a home compress, that's in general dry eye information. That's if they have any aqueous deficient part of it, talking about water consumption, nutrition, general health, that sort of thing. If those maneuvers aren't getting them the relief that they desire, then I view a good fish oil and MGrx as level 1 care. This is in-office stuff, in the sense that's where we're administering the treatment, but I don't want them to go down to the big box store and get their fish oil, because we all know that their fish oil is not going to be helpful to the patient. And then level 2 would be the IPL and the MGrx sequence, and hopefully they'll also accept a good fish oil as well, because we all know that helps. So that's my general protocol. It can vary based on the patient's needs. My summary is why I like the MGrx. I looked at thermal expression devices for a while. They've been available for a while, and when they first were becoming popular, this may date back 8-9 years, I couldn't afford one. They took up a big footprint. They had a high cost per patient, the consumables. It just seemed to me to be a likely uphill battle to get the patients to accept that treatment. And so as time went on, I knew that I had to offer it somehow, and I was looking at different devices, and I just stumbled upon David and his product, and I can't remember how, but I did, and I love its flexibility. I can treat one lid if I want. Ironically, earlier today, I saw a gentleman that had a chalazion that was going into hordeolum phase, and it wasn't real advanced, and we just treated one lid because we could, and I think he's going to be fine tomorrow and going forward. I like how the MGrx works in tandem and synergistically with IPL to improve the results and give patients the best treatment possible. Going forward, when my N number reaches, let's say, triple digits, I'd like to have a sense of, am I going to get better results? And David may be able to talk about this, because he's taken 6 years to develop the instrument, but am I going to get better results per lid if I heat and express ×4 rather than heat 4 and express 4? I haven't done it that way yet, but I'm curious, and I'm also curious the different types of MGD, if there's different results in terms of frequency of treatments, whether patients are going to end up benefiting from once every 90 days or twice a year or once a year. So that'll be interesting as time goes on to kind of get a sense of what works best for each patient. And if they perceive a benefit from it, how long does that benefit last before they feel like they're kind of falling back to their old symptoms that they used to have? And I just can't help but ponder. I don't know if anybody else, watching this might feel the same way, but I mean, I graduated from optometry school in 2000, and I never would have thought that we would have been doing this type of treatment for dry eye for patients, 22 years down the road. It's amazing that we can now help patients in this manner. I want everybody to know that I'm not a practice management consultant. One of my hobbies is I do build and develop medical offices, but other than that, I'm not a practice consultant. But a couple things I want you to keep in mind is that when you deliver this treatment, it's not just something that it doesn't take a long time, but it's not real quick either. You've got to heat up, the instrument. You've got to take care of what you're doing. If the patient's gaze isn't controlled, and if they're kind of fidgety, you can cause a corneal abrasion if you're not careful and diligent with it. So you need to block out enough time to do this and take care of patients without being rushed. The cost to provide this care to the practice is essentially equal to the cost that you deem. I've used the term contribution margin. What proportion of that instrument are you going to pay off with each treatment? You want to pay it off in 100 treatments or 1,000 or 250, plus your chair time? And the chair time is the cost that doesn't go away. plus your desired profit margin. And again, back to why I like the MGrx, it's total flexibility with no consumables. So you have control over it. You can offer, if you deem it necessary, you can offer it at no cost to the patient if that's the way you want to go with care, if that's what their needs are. I've curiously, I read articles about practices adding IPL and high level treatments. And I did read an article once about someone in a different town that, our practice is one of the first X practices in the state of Michigan to provide this treatment. And I don't know that that's the end of the curve that you want to be on, just because I always feel like, and one of my other practice specialties is vision therapy. I'm not comfortable saying to a parent that I'm the only person in our area that provides the service, because I always feel like that makes the patient or the parent wonder, well, why aren't more providing it? What's wrong with this treatment type of thing? So I always strive to be at the other end of the curve, that many of our patients have experienced relief from this treatment. And I do proactively ask patients that are satisfied if they would give a testimonial or act as a reference to someone that may want some more information. I don't think there's ever any problem from doing that. If I have a couple more thoughts here. So, oh yeah, my biography. You may not need it to make the diagnosis, but I do it whenever there's a chance that they could have MGD, because the value of that image on the screen with respect to patient education, I just think it's priceless. I mean, if I do it free, it's priceless, because patients understand, in real time, you can explain to them, hey, I can't see your glands this way when I look at them with the slit lamp with visible light. I need this infrared light to image them so I can understand. Now I can put it on the screen and explain to you. And when patients see normal meibomian glands that do not have dropout, that do not have hypertrophy, and then they see theirs, it makes treatment acceptance much more likely. And I found, ever since I started simplifying my treatment approach with the 3 different levels of treatment, patients accept the highest level of treatment a lot more of the time than I would have thought initially. Patients do want the best for their eyes and for their vision and for their health. And a couple of the couple of items of feedback that I've heard recently. Somebody said the other day, when I was explaining or going over the cost, oh, that's not a lot, because my spa treatments cost triple digits or whatever. So it's really not a lot of money in today's world of healthcare treatment. What else do I have? IPL and MGrx alone, but even especially together, are most likely the best initial treatment option for the next patient sitting in your chair with MGD. I firmly believe in that. And I know my N number is only closer to 20 right now after 6 months, but that is reflective of the results that I've seen so far. If anyone wants to connect with me, there's my email address, there's my cell phone number, text is preferred, and I'm on Instagram and I'm on Facebook. And it was a pleasure to be here. I know this isn't live, so we may not have actual questions right now, but David, was there anything else that you wanted me to go over?
Yeah, and first of all, thank you very much. Really, really well done, and some great detail, and I think real world advice there. So appreciate it. I did have some questions that had been chatted earlier, and we get these typically when we give presentations on the MGrx. So one of the questions is, what are you charging for the MGrx, and are you using combination pricing, multiple a year, or with IPL, or how are you handling that?
Absolutely. I'm probably at the lower end of the spectrum. I don't know what the average is, but my feeling is, again, with no consumables, I have a lot of control over the pricing, and I'm in the low twos. I'm 225 for the MGrx alone.
Okay.
And I know that the average is probably more in the threes. I just wanted to price it so that you have to think about the demographics of the area where you practice. I wanted to price it so that patient acceptance would be good. With the IPL, if patients choose that route, I just add it in after the second and fourth visit, and I don't up the price. That's just a package price with the IPL, so I just do it anyway. And so,
Okay, gotcha.
and I don't know. I mean, I'm assuming that the listeners, the viewers of this. I mean, I don't want to get into the whole non-competitive thing. Nobody in my area is going to be watching this. So when I added IPL. I was told that the national average at that time was 1,400 for 4 sessions. And so that's just what I do. And I do 5 sessions and I do 2 MGrx.
Okay.
And that's a reason. And that's, we've got good acceptance. Depending on, I think a practice management consultant, which I'm not, but I think one would say you want 10% of patients to balk at the price. So maybe if I'm doing a lot more, my schedule is so full, maybe I'll raise it 10% in a year. But I'm comfortable, at those levels that pays for the equipment and it pays for the chair cost.
Gotcha. And yeah, the 1,400 sounds about right to me for IPL from what I'm hearing. And I'll just address, you had asked about is it worthwhile to maybe heat each lid individually? So that would be doing the massage step on an upper lid, upper left eyelid, and then switching to the expressor and expressing it and going back and forth. And so obviously the downside of that is it adds some time, right? It wouldn't add a ton of time, but you are switching instruments, 4 times. What I can tell you is we have seen, I haven't seen a clinician do that, but I have seen a clinician do the left eye. So the upper and lower lid together with the massage, and then do expression, then go back and do massage on the right eyelid and expression. And it doesn't add a ton of time, but it adds some time. What I could tell you is in our clinical study that's been submitted for publication, we did not do that. We did, the same protocol you're doing, which is massaging both eyes, 2 minutes each, and then going to expression and expressing, one at a time. And, those results are, 40% improvement in speed score, 30 days post treatment, and, doubling of tear breakup time, and even more like a 3x on the meibomian gland scoring. So we're getting, really good results doing it the way you're doing it now. So, I don't have any data to say if it would be better to do it the other way, but I think that's about as good as just about anything that's been published. So,
well, as long as patients are getting better from doing it the more efficient way, there's probably no reason to change it.
Yeah, that would be my feeling. But yeah, well, again, thank you very much. Really appreciate it. And I do need to add one other thing. You talked about high quality fish oil a couple times. I'm gonna just be clear that's the ultra dry eye TG that we offer, and also the Vision Guard, which is the half size.
That's what I'm recommending.
You're stocking in your practice, yeah. Great. Well, again, thank you so much. We look forward to following up with you, maybe in 6 months and see how things are going. And maybe we'll have you back then.
Sounds great. Thank you, David.
All right. Thanks so much. Have a great evening.
You too.
Bye-bye. Just have probably another, 5 to 6 minutes here, if you can hang in with me. Just on our clinical study results. So this is on the MGrx, we enrolled 37 patients. We used speed score and tear breakup time, and also meibomian gland scoring to see, pre and post 30-day treatment with the MGrx. And in terms of speed score, we saw 42% improvement and a more than doubling in tear breakup time after 1 treatment. So again, 72 eyes, so definitely statistically significant, and you can see a pretty significant improvement there. Tear breakup time, like Dr. McMurrin there said, more than a doubling in tear breakup time. And I think most impressive is the gland scores. So we only did this on 26 patients, not the 37. But you can see that these patients were really badly in need of help here. This is basically a few glands producing anything, so a score of 5. And then after 30 days after one treatment, we've increased, fourfold, fivefold in terms of secretions coming from those glands. So that tells me that you now have glands producing that you certainly did not prior to treatment. So I think that's really impactful. And then some of the quotes, from the patients in the study, they can now wear their contacts again. Heard this several times, patients going from not being able to wear contacts to be able to wear them, 6 hours a day after one treatment with the MGrx. So, I think that's really meaningful and impactful, for your